As you've already heard, a lot has changed in advanced bladder cancer in recent years. We went a better part of 2 decades without a new drug in this field and with little change in the management of advanced disease. And so, I think you heard a lot of talks over and over at national meetings talking about do more neoadjuvant therapy. It's the only thing we can do to move the dial. But happily, we're in a new era in the treatment of advanced disease with these immunotherapeutic drugs. They've certainly significantly changed the management of advanced disease patients, and it remains to be seen how far that will take us. But I want to give you a broad overview of the new drugs that have come out, where they fit in, first, second-line therapy, and some of the practical issues surrounding their use. So we'll talk about the clinical activity of immune checkpoint inhibitors in urothelial carcinoma, the efficacy, and the potential toxicities of these therapies. All right, so we'll start with our audience response questions. Which of the following drugs have demonstrated an overall survival advantage in the second-line treatment of metastatic urothelial carcinoma? Docetaxel, pemetrexed, paclitaxel, pembrolizumab, bevacizumab. All right, looking good. Let's talk about this further. What immunosuppressive ligand is expressed by bladder cancer cells in order to evade the immune system? All right, so this is the basic mechanism at play. I mean, this is review of Immunology 101 going back to medical school. The beginning of the immune response starts in the lymphoid tissue when antigens are taken up by the antigen-presenting cells, complexed onto MHC class 1 and class 2 molecules, and then presented to the CD4 and CD8 T cells present there in the lymphoid tissue. The CD4 cells, remember, act more in a helper role, producing cytokines to then stimulate the CD8 cells, and the CD8 cells are then responsible for migrating throughout the body, proliferating, and finding the offending pathogen, whether it be bacteria or whether we're talking about a tumor. Within the tumor microenvironment, so the TME you see there on the right side of the slide, the CD8 cells should complex or recognize the tumor, begin the immune response with help from the CD4 cells, with help from the macrophages. All right, so part of what happens here is while you have stimulation of the CD8 cells, you also have regulation of the immune response through the inhibitory or co-inhibitory molecules, if you will. So this is PD-1. This is an inhibitory receptor on the surface of the CD8 T cell. PD-L1 is the stimulator of inhibition. So ultimately what you have is at the same time that stimulation of the immune response is happening here through MHC class 1 and 2, inhibition is happening through PD-L1, PD-1 interaction, and this is why we don't all dissolve into a pool of autoimmunity with every infection we get, because the immune system gets appropriately shut down while at the same time that it's being stimulated. But what we find in tumors is that many of them will vastly overexpress PD-L1. So even though the CD8 positive T cells are being appropriately stimulated over here in the lymphoid tissue, when they migrate over to the tumor and they recognize the tumor, they're immediately strongly inhibited, thus shutting down the immune response. So this goes back to that age-old conversation, for over a century, research has gone on saying that the immune system should clear cancer, that cancer is a failure of the immune response and that the immune response should be the appropriate treatment for cancer. But why did it take 120 plus years in order to come up with the first effective therapy? Well, this is mechanism, right? So the science underlying modern immunotherapy wasn't accidental. This was very much modern laboratory science discovery of these inhibitory molecules, first by our colleagues in Mayo Rochester, in fact, that allowed us to then design drugs to inhibit the inhibitory mechanism for the immune response. So remove inhibition to activate the innate immune response. All right, so this was systemic therapy in 2015, right? It was really simple. First-line therapy, if you're cisplatin eligible, you get cisplatin-based chemotherapy. Could be Gem-Cis, could be MVAC. If you're ineligible, we might substitute taxanes or carboplatin. And in the second line, there was no standard. Everything up to this point, we had a variety of second-line drugs, right, the taxanes, pemetrexed, whatnot. These are single-arm phase 2 studies. Up until the modern checkpoint inhibitors, no drug had ever proven a survival advantage in a randomized clinical trial in the second line. So this is all just limited small studies where we were looking at response rates. And so this really was clinical trials territory. And the median overall survival in these patients post first-line platinum is something on the order of 6 to 7 months. So very dismal outcomes. So here's the second-line data. Again, these are small series. I mean, look, we're talking 14 patients, 30 patients. I mean, this is what second-line therapy was based on. Response rates on the order of, 7 to 27%, very poor. So into this space came this next generation of immunotherapeutic drugs. And I'm going to just walk you through a handful of the studies, kind of giving equal treatment to each of the various drugs out there, because there's a lot of them now. These antibodies are targeted to either PD-1 or PD-L1, right? So some of the two different halves of this interaction, receptor and ligand. Because we're talking about cell surface proteins in both cases, either side of the interaction can be targeted. And there's slight variations, theoretical perhaps, in terms of the significance of targeting one side of that interaction or the other. But we walked through that, and the very first drug we saw with positive results was atezolizumab. So you might remember when this received its breakthrough designation by the FDA. And it was based on this study, a single-arm phase 2 study, 310 patients, all of whom received atezolizumab. They underwent tumor assessments with imaging every 9 weeks for 12 months, then every 12 weeks thereafter. And I took this picture from the phase 1 study, but it tells you the same thing. And here's just the example. I mean, you can see the retroperitoneal lymphadenopathy here, and a very impressive response. So again, to immunotherapy, not chemotherapy. And this then is looking at the overall survival on an intent-to-treat basis based upon the staining for PD-L1. Now I'm going to walk through this for all these studies, and what you're going to find in a consistent theme is, we all would like to think that it's a very simple biomarker. We're talking about PD-L1 expression on the tumor as a target, therefore IHC for PD-L1 ought to tell us who's going to respond and who's not going to respond. And you're going to see that the results are very different drug by drug, and this is a theme that has been carried out throughout the various cancers that we're treating with immunotherapy: lung cancer, melanoma, bladder cancer, head and neck, on and on. So what you see here is that patients who have the highest level of expression have the best overall progression-free survival here and overall survival. At 12 months, about 48% of patients are still alive if they strongly express PD-L1. Now this is impressive. Remember, 6 to 7 months was what we expected from chemotherapy. So once we start getting close to a year, we get pretty excited. But even in the non-responders, you're looking at 6.5, 7 months, so equivalent of chemotherapy. So even, not non-responders, even in the non-expressors, this is equivalent to chemotherapy. Now in pembrolizumab, we had the first randomized clinical trial. So this is a phase 3 of pembrolizumab versus chemotherapy, and this data came out after the atezolizumab. I'm kind of walking you through this chronologically. Randomized clinical trial, 542 patients. Again, patients who had progressed after platinum or progressed on platinum therapy or after, generally defined as 12 months. And when you say 12 months, you're talking about actually people who did fairly well. It was investigators' choice chemotherapy because this was run in Europe and the US, and there was some disagreement about what the control chemotherapy should be. But here's the overall survival. And so this is the only one of the drugs that has a clear overall survival advantage on a phase 2 clinical trial. First randomized phase 3 clinical trial with an overall survival advantage in the second-line setting. And here you see it, a clear overall survival advantage, pembrolizumab versus chemotherapy. But what I'd have you pay attention to is this down here. This is the progression-free survival curve, and this is a characteristic PFS curve for immunotherapy. We see this over and over again in different malignancies. No separation early. Okay, immunotherapy doesn't have an immediate impact. You have your immediate progressors. You'd think early on, if you choose an arbitrary endpoint, you said we want median PFS, well, the median PFS here is hardly any different. In fact, it's worse for immunotherapy, although that's not a meaningful separation. But then what you end up with is late separation that then proves to be durable. Okay, so you get a minority of patients who benefit, and yet when they benefit, the benefit is ongoing. Okay, so this is characteristic of immunotherapy, a minority benefit, and yet the duration of benefit is such that ultimately you end up with a meaningful advantage in overall survival. So again, one of the points we always have to emphasize in these studies is don't pick arbitrary cut points. We don't talk about median overall survival. We talk about hazard ratios because, you know, if you cut it off here and you say that's what's significant, then you're missing this. All right, so Durvalumab, here again, single-arm phase 2 study. This is another one of the PD-1 inhibitors. So atezolizumab was PD-L1, pembrolizumab, nivolumab, either PD-1, so the immune side of the interaction. 270 patients, again, platinum refractory, so second-line therapy. And here again, what you see is an impressive overall survival, you know, going out to 12 months. So here's your median. It's approaching something close to 12 months. Again, much better than what we expected from chemotherapy. But in this one, what I'm showing you here is the separation based upon expression of PD-L1. Now for Durvalumab, each company has their proprietary test. For this test, they choose an expression of 1% as their cut point. If you have greater than 1%, you have more durable, better overall survival. If you have less than 1%, it's less. But nevertheless, you know, you look here, the 50% is still at least on par with what you'd expect from chemotherapy. And then Durvalumab, I'm sorry, the reference I think is in, the text is black so you can't see it. My bad there. Durvalumab, so this is from ASCO GU. This wasn't yet in paper form. Now this is another one of these drugs targeting PD-L1. And what this is a waterfall plot. So this is every patient treated. Up means tumors grew, down means tumors shrunk. And you can see the inflection point for growth versus response is very impressive, right? A majority of patients get some response. One of the reasons you're seeing more and more of these waterfall plots in oncology nowadays is because we recognize that when you talk about RECIST criteria and draw this arbitrary line for percent response, RECIST fails to express what's going on here. Okay, it's not as if there's a difference, a clinical difference, between a 29% reduction in tumor and a 31% reduction in tumor. And drawing an arbitrary line at 30% really fails to express what's truly going on. So this is why we're starting to get away from talking about true RECIST response rate and starting to look at things like waterfall plots to give you a real sense of every patient who was treated. And with Durvalumab, you see this familiar story. The patients who express more PD-L1 have higher response rate. These low expressors have a much lower response rate, but nevertheless, you still see responses. It's always an important part of the story with immunotherapy. Even low responders, you see some responses. And if you're talking about a disease state where nothing else works and you're out of options, you're not going to deny your patient a chance at response, however small, even if there are no other options. All right, Durvalumab, and this is the last one of the 5 drugs I'm going to walk through, and then I'll start comparing them a bit. With Durvalumab, it's a phase 1b, 44-patient study, so this drug is behind the others in terms of development. You see an objective response rate, 18%. We'll compare this at a bit. But durability, so 75% of responders still responding at 6 months. Disease control rate, that's that inflection point on the waterfall plot, about 52%. So here's what we end up with. We look at these 5 drugs, all of them with positive results, all of them making their way into the guidelines. And you see this overall response rate hovers somewhere around 20%. Okay, this is the RECIST response rate, that arbitrary cut point. Not terribly impressive, but nevertheless better than what we saw with chemotherapy. You compare high expression of PD-L1 to low, and across the board, you always do a little better when you have higher expression, except here with pembrolizumab, where it doesn't seem to have mattered. Each of these drugs uses a different assay, the proprietary assay for the company, so you just can't compare assay to assay. You have no idea how to compare these results. Median overall survival, again, more impressive than what you'd expect with chemotherapy. But keeping in mind, I mean, the bigger studies have lower overall survival than the lower ones, and this isn't surprising, right? These smaller studies are phase 1 studies, and what happens on phase 1 is that the oncologist is much more careful which patients you pick. You know, it's all patient selection, right? Phase 1, first in man studies, you haven't treated patients before, you don't know how it's going to go. So these tend to be healthier patients on these studies than you see on larger randomized trials or 200, 300, 400 patient studies. Response kinetics, as I was getting at in that PFS graph we were looking at earlier, is an important point to keep in mind here. So I have what we call swimmer's plots from 2 of the drugs. So the swimmer's plot is again, you have each of the patients, and the analogy here is this is a swimmer in their swim lane, okay? This line represents a patient on a drug, here pembrolizumab, here the chemotherapy on the control arm. Arrows at the end mean the patient is still on the drug at the data cut point. X's at the end mean the patient has progressed and come off drug. The yellow dot tells you when response was first detected. So radiographic RECIST response. And what I would have you get out of this is multiple things. One, the median time to response is somewhere around 10 weeks or 9 weeks. In this study, 9 weeks is when they did the imaging. Very few patients are going to respond earlier, and that's because very few patients have disease assessed earlier than that. But what shouldn't be missed is that some of the responses are happening out here at 6 months. And when you compare the chemotherapy to immunotherapy, here again you see that there is a much larger proportion of responses that come very late in the disease course. With chemotherapy, you know pretty quick. You know by that 9-10 week mark if the patient is responding or not. Whereas with immunotherapy, you're not sure. In fact, a common phenomenon we see with immunotherapy is sometimes the tumors get a little bit bigger at that first scan here at 9 weeks and then subsequently shrink. And we can wave our hands with explanations of this. We don't think it's flare. We really talk about this as inflammation, right? You induce an immune response. I mean, what happens when you have an infection anywhere in the body of an immune response? You get swelling, you get engorgement, right? We think that's what's happening in the tumors, and then you get these patients who respond much later. So, of course, that makes interpretation of response much more difficult. How do you know who's responding versus who's pseudo-progressing, as we call it? The other thing to take out of this is look at how many patients are still on therapy, all these yellow arrows. Ongoing therapy more than 12 months out. Chemotherapy cannot be tolerated for 12 months. These regimens that we talk about for these bladder cancer patients, this is not something that people can stay on. Remember, pembrolizumab is the same drug that President Carter got for his melanoma. He is a very frail 90-year-old man. I mean, you remember seeing those news press conferences with him. Immunotherapy is something that can be given to very poor performance status patients because the toxicities are very mild for most patients and manageable, and I'll get into that a bit here. So durability of response, and that's what I was showing you with the swimmer's plot. For those patients who are responding, patients responding more than 6 months is greater than 75%. And in fact, patients responding more than 12 months for some of these drugs where the data is going on longer is still exceeding 2/3. This is durable response. What we don't know is how long that response will go on. You know, the very first tumor that was treated with immunotherapy, the first positive clinical trial with immunotherapy, if you exclude allogeneic stem cell transplant, would be ipilimumab in melanoma. Remember, melanoma was a terrible disease not very long ago with no effective treatments. And with ipilimumab, we now have 10-year survival data showing that over 20% of patients who receive ipilimumab are still disease-free at 10 years. I would call that cure. Okay, 10 years disease-free is cure. We have no idea yet if that's going to translate into bladder cancer. In lung cancer, we haven't seen it. In kidney cancer, not so much. Go tumor by tumor, the durability response is different. But I will tell you that bladder cancer is tracking better than most of those other malignancies. It's not quite at the melanoma level, but it is looking that way. So there's reason for optimism. How many patients are still going to be responding at 2 years, at 3 years, at 5 years? We don't know yet, and only time will tell. But again, there's reason for optimism here that we certainly didn't have just 2 years ago. Biomarkers for response, a variety of things have been looked at, and I don't think we need to delve into this too deeply. But there's a lot of different biomarkers you can look at. You can look at the PD-L1 expression. We can look at the tumor mutational signature. Amongst all the various cancers, bladder cancer ranks fairly high on the total mutational burden. Remember, being a smoking-related malignancy, the mutational rate is quite high. The highest amongst all cancers is melanoma. Then lung cancer and bladder cancer are fairly high up there. Head and neck's also up there. And in theory, having a higher mutational burden should connote a higher response to immunotherapy. I mean, we think about this as being a probabilistic phenomenon. The more mutations you have, the more neoantigens you have, the higher the chance the immune system has to respond to therapy. Well, we can dig deeper into that and really talk about subtypes of bladder cancer. And the TCGA data set has this, for example, luminal 1 type versus luminal 2 versus basal. And we start looking at this and we see perhaps luminal 2 has a higher response rate. We see that in the atezo data. The Nivo data looks at the interferon signature that's familiar from other studies. Chemokine signatures certainly might have some significance. But none of these are definitive yet. So ultimately, none of these need to be tested or evaluated before prescribing therapy for a patient. Median time to response, as I was talking about, 2 to 3 months. We recommend first imaging, depending upon the timing of the cycles, 9 to 11 weeks into treatment. And patients can continue to receive medication even if they progress initially because of this phenomenon of pseudoprogression. We don't want to miss it. You know, keeping in mind in the second line, you don't have anything to do in the third line. I think you can see this. The toxicity profile, this is just for one of the drugs. This is atezolizumab, but generally it's fairly similar amongst all the drugs, so I'm not going to walk through all of them. You know, grade 3-4 toxicity rate is about 16%. Remember, grade 3-4 is when, grade 3 is when intervention is required, some kind of therapy, some kind of management of the toxicity. Grade 4, generally you think in hospitalized patients. Fatigue is the most common toxicity. You know, fatigue, of course, in an advanced cancer patient is expected. Rash we see generally manageable, nothing too dramatic. You know, some nausea, some decreased appetite. Again, these are very mild, not grade 3-4. The toxicities we worry about, pneumonitis, so autoimmune inflammation of the lungs leading to dry cough, perhaps shortness of breath. This can be an issue in patients who have pre-existing lung disease, or for example, patients who have pre-existing interstitial lung disease, which has an autoimmune etiology and thus can be exacerbated by being on immunotherapy. Autoimmune colitis causing diarrhea, not nearly as bad as what we used to see with ipilimumab. Generally, again, very manageable. The grade 3-4 rate is very low. Arthralgias, myalgias, neuropathies, almost any autoimmune disease you can think of can manifest. And as a general rule, if your patient has an autoimmune disease going into this process, it will get worse. It does affect whatever is innately already going on in the patient. But here's what we're looking at. Overall grade 3-4 toxicity rate somewhere in the order of 5 to 15, 16%. This is why these therapies are very manageable and realistic, even for the oldest, kind of frailest patients. So this is systemic therapy in 2017. It's a very different landscape than what we had. You know, I just showed you some of the studies. I didn't show you the first-line studies, but atezolizumab and pembrolizumab are now recommended by guidelines in the first-line setting as well. When we say platinum refractory second line, we're also including patients who had neoadjuvant therapy and progressed within the first 12 months post-neoadjuvant therapy. And in the second line setting, then you have 5 different drugs which can potentially be used, as well as then the traditional chemotherapeutics that we're well familiar with. Thank you.